Assalamu alaikum, dear colleagues. It's a great pleasure for me to be here, and I'd really like to thank Dr. Wiam for the invitation and thank our chair lady for the introduction. It is indeed a challenge to come and listen to a talk on obesity right after lunch, so I'm not very sure about the timing, but I'm very sure that I'm not going to make you feel guilty for having the Ali that you just enjoyed, which I did too, as a matter of fact. But I am going to be talking about a challenging population, and that's obesity management in adolescents. So first, here are my disclosures. And the outline of my talk will be to really highlight some of the clinical features that warrant a further diagnostic workup for those rare genetic causes of obesity in adolescents. And then I'm going to highlight some of the strategies that we could use to support these special children with their families, and then review the current clinical efficacy and safety evidence for the MC4R agonist, because by far this has been the most exciting development in the management of genetic obesity. So we know that obesity in childhood predicts the presence of obesity during adolescence, which in turn is a very strong predictor for obesity in adulthood. And it is indeed the most common chronic disease in adolescents. So what is adolescence? If you remember your own self a few years ago maybe, or if you have children that are going through adolescence currently, you know that it's this peculiar phase that we've all had to go through, where you really don't know yourself. You're not a child, and they don't consider you an adult either. Rapid physical growth, changes in body composition, both sexually and psychologically. But the WHO really defines an adolescent as a young person in their second decade, so between the age of 10 to 19, so the teens. And in our service, we start seeing adolescents at the age of 15. Why we have this specific cutoff, it's not really clear. It's a very arbitrary cutoff. I think the pediatric service were just tired of them at that point and said, right, shoo and go off and see the adult physicians. So it may vary from center to center, but we see them from the age of 15. And they're a very interesting bunch of people to look after. So what is really important and why we're discussing this is, of course, because we know that obesity during childhood and adolescence predicts a higher adult mortality. We know that there is an increased risk of both 64% increased risk of mortality and an 89% higher risk of later life cardiovascular related death. And then, of course, we have all the other obesity-related comorbidities that we see in adult life, so diabetes, hypertension, dyslipidemia, all of which can be managed once the child's weight is under control. So this is to just show you the global prevalence of obesity, and what I wanted to highlight from this graph is the fact that within the Central Asia, Middle East, and North African region, we've had the highest increase in obesity over the last years. So we have a really huge problem, if you see, from the 1980s up until 2016 when this data was collected. And then this is the trends in childhood obesity over the years. So if we look at 1975, I don't really have a pointer, but I don't know if we do we have a pointer? Do we have a pointer? No? Okay. Anyway, if you look at 1975, the bars there are very small, and then in 2016 you have this exponential rise in the obesity rates in both boys and girls. And then the projections are even more alarming. We know by 2 years ago, there were 158 million children with obesity. By 2025, that's going to go to 206. And if we don't do anything by 2030, it's going to be almost double that. Now, this is an old publication, but it also highlights the sort of gender differences within the Gulf countries. So Bahrain had 2 surveys, one in 2000 and 2008. And what is interesting for Bahrain is that the rates of overweight and obesity were higher in boys, highlighted in blue, than in girls, whereas in Kuwait, Qatar, and the UAE, we had more or less similar rates of obesity between the two genders. So what are the causes of obesity? Well, obesity is really multifactorial, and we have the sort of common garden obesity that's related to environmental factors, the polygenic obesity, and then we have specific genetic factors which I will elaborate on. So of the environmental factors, of course, diet is always number one, and you know, as we all know, our diets have changed dramatically over the years to more convenience and fast foods. And the size, the portions of the food that we consume is also much more than what grandma probably used to eat. Lack of sleep, there's a lot of screen time. In my days, I won't tell you how long ago that was, the kiddie channel used to start at 5 o'clock in the evening and it used to stop at 8. So we just had 4 hours of screen time. My kids grew up in an environment where they have screen time for 24 hours. You know, you can switch on the television and you always find something to watch. Then there is, you know, not just screen time, the physical inactivity. Right? The kids are spending a lot of their time also just by doing homework on the devices. And sometimes you wonder whether it's just homework that's being done, but they do spend a lot of time on electronic devices. Medications can also be important. Children with ADHD, for instance, who are medicated, may have an increased risk for developing obesity. And then we have the common genetic variants that we will talk about. But what's also important for us to realize is that the 2 CNS pathways that play a key role in regulating not just our eating patterns, our cravings and weight, is really the satiety center on the one hand in the blue that I've highlighted, and the reward system. And I bring this up because I think for the adolescents group, the reward system is really important. So our strategies need to center around that area of the brain. And then you have the metabolic adaptations, the biological factors that really make it so challenging and difficult, not only to lose weight, but to maintain the weight loss. So if for a good reason you decide I'm going to go on a low-calorie diet, the first thing that's going to happen is that your ghrelin levels are going to go up, your PYY and CCK are going to go down, and the net result of that is you're going to feel more hungry, and of course that is going to drive you to try and eat more. On the other hand, the energy expenditure goes down through a decrease in the sympathetic nervous system, and as a result of that, it becomes very difficult and really challenging for us not only to get that weight loss that we want, but once you've had some weight loss, to actually maintain it. So here now I'd like to sort of concentrate on the monogenic forms of obesity and the differences between syndromic and monogenic. The syndromic ones are usually associated with severe early onset obesity, and these individuals usually have neurodevelopmental disorders, and they may have also these dysmorphic features that may be easy to identify. And such syndromes that most of you will have heard of, but probably are not managing, because these are individuals who will be managed by the pediatricians, are things like the Prader-Willi syndrome, the Bardet-Biedl, and the Alström syndrome. And then monogenic obesity is also associated with extreme behaviors usually related to hyperphagia and insatiable hunger. So this is the child who says, I want food almost all the time. And then it's usually caused for the majority of them by autosomal recessive variants, either in the leptin receptor, leptin, POMC or PCSK1, and the MC4R, which has now got a treatment. So fortunately, these genetic diseases are quite rare, as you can see there. We don't have the true prevalence, largely because there's this infrequency of genetic testing. But some of the clinical characteristics that may point out to this adolescent or child having a genetic cause for their obesity, and this is what most parents would like to hear. You know, they would rather like to hear that it's not my fault, it's not my responsibility, there's something genetic about my child and that's why they're so big. So if you've got a child who has severe early onset obesity, that might be a clue that this is a genetic form. The insatiable hunger, they're hungry all the time, no matter how much food you give them, they always want more. And then they may have these sort of other syndromic features that include neurodevelopmental delay, a failure to thrive, or they may have abnormalities within other organ systems. And so these are conditions that the pediatricians would be very much familiar with, especially when they present with very sort of typical features. However, they will at some point grow, and then we will have to be managing them in the adult services. And sometimes if you've got very subtle dysmorphic features, they may actually be missed and then present to us during their adolescent years. So I'm not going to go over all of those in sort of great detail. So some of the challenges that we know about diagnosing both monogenic and syndromic obesities, because one, genetic testing is not available to everybody. Not all services have access to genetic tests, so they're quite underutilized. And then the definition of severe early onset obesity is really unclear. There is lack of awareness among healthcare professionals, and the clinical features also are poorly understood. So it's a kind of very specialized area of work. So what do we do then for testing the rare genetic diseases of obesity? As I've mentioned, the sort of individuals that we may consider to send for genetic tests are those who've had early onset obesity, hyperphagia, if there's a family history of severe obesity, or the individual is resistant to the traditional weight management strategies. And we should remember that adults with severe obesity may have a missed diagnosis of one of these genetic variants. So the obesity gene panels really focus on POMC, PCSK1, leptin receptor, and the Bardet-Biedl syndrome and MC4R. These we're able to diagnose quite accurately using the genetic tests. So what about the management then? And the management is really quite multifactorial, and it needs to be holistic. So it's not just about the dietary interventions. One needs to consider the socioeconomic status of the individual, sleep hygiene, stress and mental health, which fortunately has taken center stage nowadays. It's talked about in schools, it's talked about in the media as well, because that is part and parcel of the management of obesity. Medications, making sure we're not giving those children drugs that can actually exacerbate their weight gain. So behavior changes, of course, this is perhaps the most challenging after diet. And it's always helpful within a multidisciplinary care obesity service that there's a psychologist or a clinical nutritionist who is trained in cognitive behavior therapy, because then they can help with the behavior change that is really required and necessary for patients to take on these behaviors that we want them to. So weight monitoring, the use of food diaries, and they don't need to be paper-based as I've shown here. It can be done digitally, since most of the kids these days like the digital world. Making sure that they're sleeping well. Now, family meals are really important because then it sort of avoids them having to order the fast foods, because now you don't even have to go out at any time of the day, any time of the night. You can have Deliveroo bring in your meals. So we really need to emphasize on minimizing the processed foods and, of course, decreasing the screen time. Dietary considerations, there's a lot in this sphere, but the most important thing to remember that is that it's got to be really individualized, and there's no one single diet that could be said to be better than the other in terms of the macronutrient options. However, having said that, we do know that plant-based diets tend to do a lot better in terms of weight loss than other forms of diets. And of course, the response to the different kinds of diets may be very variable depending on the individual. So what are these sort of approved treatments for obesity? So first of all, let's look at the goal. And the goal is not just weight loss, but it's weight maintenance as well. We know that this is a chronic disease, and of course, improvement of symptoms. I will talk about the setmelanotide in a few more slides, but the other drugs that are now sort of approved are the GLP-1 receptor agonists, things like which act mainly on the neurohormonal systems, topiramate and bupropion. Some of them can be used as off-label indications. So, looking at the average weight loss that we may expect with some of the pharmacotherapy, with things like phentermine, topiramate in adolescents, we can use them, but we need to use them cautiously because they can increase the suicidal risk as well. By far, the GLP-1 receptor agonists have been the most successful in terms of pharmacotherapy, and they are now FDA approved for the management of adolescents. Orlistat has a long history. We used it probably much earlier on, but it's fallen out of favor because of the side effects. Tirzepatide, a lot of success in the adult landscape. We still have the Surpass Peds, which we're waiting for the results, and I'm sure if that's positive, the FDA will approve that as well. So this is the effectiveness of liraglutide in the pediatric population. They can, achieve almost more than 10% reduction in the body weight, and therefore it becomes a useful adjunct in their treatment. Step Teens was also very successful, and just last year in December, we had the approval of semaglutide for obese and overweight teenagers. So I know this is, I don't know whether you can actually see it, but it just sort of highlights some of the FDA-approved treatments for obesity in children, both the oral and the injectable ones. And I just wanted to draw your attention to probably topiramate and bupropion naltrexone. We don't use those. I don't have much experience with those agents because they are sort of limited to the neuropsychiatrists. So we use more of the GLP-1 based therapies. What about MC4R? And there's been a lot of excitement, particularly for those individuals with monogenic obesity. So the MC4R pathway is really an integral component in the central melanocortin pathway, which is important for the regulation of both appetite and energy expenditure. And setmelanotide is an MC4R agonist, which is now approved for the management of patients above the age of 6 years who have diagnosed monogenic or syndromic obesity. It is not effective in those individuals in heterozygous individuals, and it's definitely not for use in polygenic forms of obesity, because there's been a lot of excitement with this, and parents are asking whether this can be used in just common garden type obesity. This is some of the response in the different conditions, and it seems to work much best in those with POMC deficiency. Considerations for use, it is licensed for age above 6, and between the age of 6 to 12, they get 1 milligram subcutaneously daily for the first 2 weeks, and then it can be up titrated. It can be down titrated in case they develop some sort of side effects and then they're not able to tolerate it. And for those that are older than 12, they can start with a 2 milligram dose and then follow on with a 3 milligram dose as well. Renal adjustment is required for those who've got an eGFR that's between 15 and 30. And the common adverse events or reactions that can be seen is skin hyperpigmentation. There might be injection site reactions, headache, and some GI adverse events as well. How about patient monitoring and counseling? It's important if a patient has not achieved more than 5% weight loss within a 12 to 16 week period that the treatment should be stopped. And for the Bardet-Biedl syndrome, we need to discontinue the treatment if within a year they have not achieved at least 5% of their weight loss. Some few counseling points would be around storage and the proper administration of the medication, and when to seek help when they've got adverse events. And then GLP-1 has also been used in these genetic forms of obesity with some success, as you can see there, the control in the gray and those with the MC4R in the blue, and they did have some reduction in their weight with GLP-1 receptor agonists. Can they be combined? Well, there aren't any studies at present in humans, but rodent studies do show that the combination might be beneficial. And theoretically, we think that, you know, if you combine the two treatments, you might get a synergistic effect. So what about the other investigational therapies? Well, tirzepatide, we're still waiting for the SURPASS PEDS, and if we see the sort of success that we've had in adults, it probably will also be approved. Oxytocin is one of those other investigational therapies for obesity, intragastric Botox, and things like tesofensine, metoprolol will have the phase 2b studies expected to be completion in March this year. So that's tirzepatide. I heard once Julio Rosenstock describe it as the gorilla GLP-1 because of the amount of weight loss that you can actually get from this agent, you know, almost near to bariatric surgery. So I'll just finish off with highlighting some of the challenges that we face in both the diagnosis and treatment. It's important that we actually look for depression because this may be the underlying driver for obesity in adolescents. There's a lot of peer pressure that they have to go through, much more than we faced in our time. Binge eating syndromes and stigmatization, having social support as well is really important. Isolation in a sea of experts. These children usually come feeling very, very lonely. They're accompanied by family members. Mom and dad is usually there during the consultation, but when you take the parents away, you find that these children are very vulnerable and usually feel very, very lonely. So they are struggling because of their obesity, you know, finding friends sometimes, and then there may be a disruption of their normal childhood events. They're not able to participate in normal childhood activities. They tend to be left out in sports activities and so on and so forth. There was a child who came crying, I remember, and she says, I don't get invited to birthday parties because, you know, they say I'm too big, you know, and it's really sad to hear things like that. Finally, the diagnosis, of course, helps both the patient and the caregivers because, you know, there's a potential to reduce the stigma around it. It alleviates those feelings of guilt. It's not their fault. It's not the parents' fault. care has to be done in a multidisciplinary fashion. And then it's important that we address obesity in adolescence so that we can prevent obesity in adulthood. So I'll just summarize with these few key points that severe obesity is really escalating, and life-based therapies have modest effects in changing the trajectory of the disease. Treatment for obesity needs additional and more efficacious treatment. Currently, it's just the GLP-1 receptor agonists really that have been the most successful. And the treatment has to be tailor-based on the age of the patient, the severity of the disease, and the presence of associated comorbidities. So anti-obesity pharmacotherapy should be utilized in these patients who failed attempts at weight loss after lifestyle modification, and syndromic and monogenic and hypothalamic obesity and other severe forms of obesity which remain resistant to standard treatment options can also need to be identified. And with that, I'd like to thank you for your attention, and I look forward to your questions. Thank you.